students, welcome to today's explainer session. I know hematology can sometimes feel like a massive, overwhelming puzzle, but today we're going to make your fundas absolutely crystal clear. We are taking a deep dive into immune-mediated hemolytic anemia. Dekho, this is an incredibly high-yield topic for your exams. Ratta mat maro. Please don't just blindly memorize. Today, we're going to build a conceptual framework so strong that you can easily tackle any clinical vignette they throw at you. Okay? Let's dive right into this.
Here is our quick roadmap for today. We'll start with the basics of immune hemolysis, master the Coombs test, and break down the classic warm versus cold AIHA. Then we'll tackle peripheral smears, PCH, drug-induced causes, and wrap up with treatment protocols.
Section 1. Intro to Immune Hemolysis. Let's build that strong foundational classification, which, trust me, is the master key to cracking any MCQ.
When a patient presents with acquired hemolytic anemia, your brain should immediately split the diagnosis down two distinct pathways, immune and non-immune. Today, our lens is entirely focused on the immune branch. Under immune hemolysis, we've got autoimmune, which further splits into warm, cold, and PCH. We also have alloimmune, like hemolytic disease of the newborn, and finally, drug-induced hemolysis. Keep this mental roadmap locked in your head as we move forward.
Now, what exactly is the core definition of autoimmune hemolytic anemia, or AIHA? Listen carefully here. It is a rapidly progressive anemia, and the hemolysis is primarily extravascular. When you see a patient in a clinical scenario presenting with a sudden, rapid drop in their hemoglobin, it strongly suggests an acquired pathology like AIHA. Mark these buzzwords down in your notes right now. Rapidly progressive and extravascular. Clear high?
Moving to Section 2, Mastering the Coombs test. So the patient is hemolyzing. Let's figure out how we actually diagnose this clinically.
SoCo for a second. Really think about it. How do we definitively differentiate immune from non-immune hemolytic anemia in the lab? What is the absolute gold standard tool we need to order?
Exactly. It's the Coombs test, specifically the direct Coombs test, also known as the direct antiglobulin test, or DAT. The laboratory mechanism is wonderfully simple. Step 1. You take the patient's RBCs. If it's AIHA, these are already coated with antibodies. Step 2. You add a reagent, which is a polyvalent anti-human immunoglobulin. Step 3. If those antibodies are indeed present on the RBCs, the reagent binds them all together and causes agglutination. If you see agglutination, bam, the test is positive, and you have officially confirmed an immune hemolytic anemia.
But wait, what about the indirect Coombs test? The crucial conceptual difference is right here, and it's super important. The direct Coombs test detects antibodies sitting directly on the surface of the RBC. The indirect Coombs test, on the other hand, detects antibodies freely floating in the circulation. For diagnosing AIH, the indirect test just isn't always reliable, because finding floating antibodies can be of doubtful significance. Always rely on the direct Coombs test to prove those RBCs are actually being targeted.
Section 3. Warm versus cold AHA. This is arguably the most highly tested distinction in all of hematology. Let's break down this classic battle.
Let's use a very simple mnemonic hook to lock this into your memory forever. Warm AIHA is driven by IgG antibodies. Think G for garam, which means warm. Cold AIHA is driven by IgM antibodies. Think M for macroglobulin or MAHA, the big one that clumps up in the cold. Warm AIHA reacts at normal body temperature, 37 degrees Celsius, and presents as a subacute, rapidly progressive condition, usually over 1 to 2 months. Cold AIHA, however, reacts at 0 to 4 degrees Celsius and acts as a chronic, indolent disease. Females are affected slightly more than males overall, but understanding this fundamental temperature and antibody difference is your absolute key to these questions.
And knowing where these diseases come from is just as critical. Both can be idiopathic, sure, but you absolutely must know the secondary etiologies. For warm AIHA, keep an eye out for autoimmune diseases like SLE, rheumatoid arthritis, or malignancies like CRL, and infections like HIV. Drugs like alpha-methyl-dopa can also trigger it. Now for cold AIHA, the trigger words in your exams will be Wallenstrom's macroglobulinemia, or infections like Mycoplasma pneumonia, EBV, and cytomegalovirus. When you see a patient with atypical pneumonia who suddenly develops anemia, your brain should immediately scream cold AIHA.
Section 4. Smears and clinical features. Let's shift our focus to what is actually happening at the cellular level.
This is a massive conceptual point, so pay attention. Where are these RBCs actually dying? In warm AIHA, the IgG-coated RBCs are recognized by the Fc receptors on macrophages primarily in the spleen. This pan-agglutination leads to extravascular hemolysis, which is exactly why these patients get moderate splenomegaly and jaundice. But in cold AIHA, the IgM-coated RBCs trigger complement activation, and they are primarily recognized by Kupffer cells in the liver. So remember, spleen for warm, liver for cold.
Deco, when we look at the peripheral smears, they are beautifully distinct. In warm AIHA, the splenic macrophages literally take bites out of the RBC membrane, leaving behind these dense, round, variable spherocytes and fragmented RBCs. But in cold AIHA, because of the IgM, you see massive RBC agglutination, literal clumps of red blood cells right there in the peripheral circulation. Clinically, this clumping in the extremities causes acrocyanosis when the patient goes out in cold weather.
Let's zoom in just a bit more on the warm AIHA smear. You can clearly spot schistocytes, which are those fragmented or helmet-shaped RBCs. You'll also see polychromatic RBCs with a slight blue tinge, which represents your reticulocytosis. This perfectly gives us our classic diagnostic triad for warm AIHA: anemia, spherocytosis, and note that these are variable in size, unlike the uniform ones you see in hereditary spherocytosis, and finally, reticulocytosis.
Before we move on to the next section, I have to highlight a super high-yield MCQ topic, Evans syndrome. If a patient presents with warm AIHA, but their platelet count is also crashing because of immune thrombocytopenia, they have Evans syndrome. It is very frequently associated with common variable immunodeficiency, or CVID. Do not let this sneaky combination trick you on test day.
Section 5. PCH and drug-induced hemolysis. Now let's cover some special, slightly more complex clinical scenarios.
First up is paroxysmal cold hemoglobinuria, or PCH. What's really fascinating here is the unique two-step temperature-dependent pathogenesis. It's caused by the Donath-Landsteiner antibody, which is a polyclonal IgG. In the cold extremities, right around 4 degrees, it binds to the P antigen on the RBC, but it doesn't destroy it just yet. Then, when the blood circulates back to the core body temperature of 37 degrees, it triggers massive complement activation and acute intravascular hemolysis. Remember, the investigation of choice here is the Donath-Landsteiner test, and it has a classic, highly tested association with tertiary syphilis.
Next, let's totally deconstruct drug-induced hemolysis. There are 3 distinct pathways, and you simply must memorize the classic drug for each one. Number 1, autoantibody-mediated. The drug, like methyldopa, alters the RBC membrane, causing the body to start producing antibodies. This becomes drug-independent once it starts. Number 2, immune complex-mediated, occurring at 37 degrees. The drug and antibody form a complex that just sticks to the RBC. Think quinidine and rifampicin here. Number 3, adsorption. The drug itself completely coats the RBC, and then antibodies target the drug. This famously happens with high-dose penicillin and typically causes extravascular hemolysis.
Section 6. Treatment and high-yield summary. Okay, Beta, let's bring it all home and look at the clinical protocols to actually manage the patient sitting in front of us. The treatment strategy completely diverges depending on your diagnosis. For warm AIHA, the absolute first line of treatment is steroids. You hit them with 1 mg per kilogram per day for about 4 weeks and taper it down slowly. If they relapse, you bring in rituximab. Other backup options include cyclophosphamide or mycophenolate mofetil. Splenectomy is theoretically ideal because the spleen is the main site of destruction, but it's really not preferred nowadays due to serious infection risks. Conversely, for cold AIHA, steroids don't work well at all. The treatment of choice offering the best prognosis there is rituximab. Let's do a really quick visual recap of the PCH and drug-induced concepts we just discussed. I want you to lock this framework into your visual memory right now. Remember the Donath-Landsteiner antibody for PCH binding the P antigen? Remember methyldopa for autoantibody, rifampicin for immune complex, and high-dose penicillin for adsorption. Got it? I want to end this session by throwing a classic clinical vignette question right back at you. If your patient presents with a rapidly progressive anemia, variable spherocytes on their peripheral smear, and a strongly positive direct Coombs test with IgG, are you thinking warm or cold? And what is your absolute first-line treatment? Yes, you are thinking warm AIHA, and you are reaching straight for the steroids. Excellent work today. I hope this structure really helped you lock in these concepts. Keep reviewing these notes, trust your fundus, and you'll ace these questions every single time. So,
what's the next complex topic you're going to master? Until next time, keep learning.